Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through neuropharmacology. And we're going to talk about a few different sections. We're going to go through sedatives, we're going to go through anti-seizure medications, we're going to go through muscle relaxants, and we're going to go through the primary neurological degenerative diseases. Let's start there. Let's go through the basic pathophysiology of Alzheimer's, myasthenia gravis, Parkinson's disease, and multiple sclerosis. We'll do a real quick review. Alzheimer's disease, the patho there is that brain cells die over time, and that's presented by memory loss and confusion. Myasthenia gravis is the body blocks muscle nerve signals, and it causes muscle weakness. Parkinson's disease is where the brain loses dopamine, and it ends up with a lot of musculoskeletal issues such as the classic shaking, shuffling gait, things like that. And finally, multiple sclerosis, the body attacks the nerves, and that results in muscle weakness, vision problems, balance problems, and other neurological functions. Most of the medications that we're about to learn that treat these four degenerative diseases only manage the symptoms and hopefully slow down the progression of the disease. But these diseases do not have a cure. All of these diseases, the medications we're going to give them, the recommendations, the treatments, these are all to slow down the progression and improve their quality of life. We cannot cure any of these diseases as of today, and we're filming this mid-2025. There's billions of dollars of research into some of these, specifically Alzheimer's disease, but as of right now, we don't have a cure. Let's start with the first class of drugs. We have acetylcholinesterase inhibitors. That's a mouthful. The drugs we're talking about are donepezil, galantamine, rivastigmine, and a few others. So these drugs are going to be used for two different diseases, but let's start with talking about it for Alzheimer's disease. But let's first understand how it works. Acetylcholine is something that we have found that if we increase the levels of acetylcholine, Alzheimer's patients do better. How do we increase the levels of acetylcholine? Well, I can't just give a patient acetylcholine. However, the body is constantly producing acetylcholine and getting rid of it, just like the body is constantly producing and getting rid of everything from red blood cells to serotonin. So the body's constantly producing and getting rid of it. Well, I can either increase the body's production or I can stop the body from getting rid of it. If the body is no longer getting rid of this, but it's still producing it, the levels will go up. So that's what this drug does. Acetylcholinesterase is an enzyme that gets rid of acetylcholine. Acetylcholinesterase inhibitors inhibit, they block the body from getting rid of it. Therefore, if the body's not getting rid of it, the levels come up. That's how this drug works. It's used to treat Alzheimer's disease. The primary symptoms are the GI symptoms that patients get when they first start treatment. Plus, it can also cause bradycardia, pretty rare side effect. Let's talk a little bit about neostigmine and pyridostigmine. Both of these medications have additional usage. These are used as a neuromuscular blocker reversal and to treat myasthenia gravis. Physostigmine is another drug in this class, again, with also these separate uses. So most of the drugs on this list are for Alzheimer's disease. The three mentioned here specifically are the ones that would be used for myasthenia gravis and the other indications that I just mentioned. So that is the first class we're covering. This is acetylcholinesterase inhibitors. Now let's move on to the next class of drugs. And now we moved on to Parkinson's disease. So far we covered Alzheimer's disease and myasthenia gravis. Now let's do the next one. Parkinson's disease. This drug class is called a dopaminergic class, and the drugs over here are levodopa, carbidopa. I have a star next to entacapone because technically, and first of all, I have no clue if I'm pronouncing that correct or not, just go with it. But that drug is actually a COMT inhibitor, which we're going to talk more about in just a second. But let's back up. Levodopa, carbidopa. What's the mechanism of action? Levodopa increases dopamine synthesis, dopamine production in the brain. Carbidopa prevents the breakdown of levodopa, so it allows more levodopa to enter the central nervous system. Entacapone is actually a COMT inhibitor, and this also prevents the breakdown of levodopa, but in a different place. This is in the peripheral tissue. I don't know how in-depth your nursing pharmacology class is going to go into. Obviously, all of these drugs have one end goal, and that is to increase the level of dopamine in the brain of a patient that has Parkinson's disease, because an increased level of dopamine will improve the patient's function. What do we use this for Parkinson's disease or Parkinsonism? I'm not going to get into that right now. The adverse effects or side effects are going to be nausea, vomiting, dyskinesia, that's difficulty with movement, orthostatic hypotension, as well as psychosis. This drug, specifically levodopa, carbidopa, is considered the most effective drug for the treatment of Parkinson's disease. Now, that doesn't mean it's going to be the first-line drug, because this is a pretty potent agent. We may often try, such as with the next drug class we're going to talk about, we may often try with a less powerful agent if we caught their Parkinson's pretty early on. However, for the vast majority of patients that have Parkinson's disease, because this is the most potent, the most effective medication, this is oftentimes where they're going to end up, not necessarily where they're going to start. Patient education, make sure you tell the patient to take it with food. Now let's talk about wearing off effect. Most drugs have a specific interval when the drug should be taken, every 6 hours, 8 hours, 24 hours, etc. Wearing off effect is something that we mentioned over here with Parkinson's, but technically it can apply anywhere. And it's where when a patient gets closer to the time of their next dose, they already notice their disease symptoms returning. That's called the wearing off effect. And we have a few different things we can do for that. We can sometimes make their doses more frequent. We can sometimes increase their dose, or we can sometimes add on, such as carbidopa or entacapone, if we were only giving them a partial, because this drug does come as levodopa with carbidopa, and levodopa with carbidopa and entacapone. So we can have a lot of options on how to address the wearing off effect if a patient experiences that. Next, we have dopamine agonists. Dopamine agonists include apomorphine. We don't understand the mechanism of action, but again, we do know that they work as dopamine agonists. They activate the dopamine receptors. What do we use this for? For Parkinson's disease? Side effects. It has a bunch of neuro and GI side effects. Plus, it can cause insomnia. Remember, anything that can cause insomnia, nursing tip, it has to be, or nursing test tip, it has to be taken in the morning. Patient education, also take it with food to reduce those GI symptoms. Again, that's a pretty common rule. If a drug can cause nausea, take it with food unless told otherwise. Next, we have another drug for the treatment of Parkinson's disease. This is going to be the MAO-B inhibitors, and this is selegiline. This drug works by blocking the breakdown of dopamine. Again, we're looking to increase that level of dopamine. So if MAO-B breaks down dopamine, if it gets rid of it, we're going to block that from happening. The side effect of this one is insomnia. Patient education, that it should be taken early in the day. They should avoid any food that contains tyramine. If you already watched our mental health lecture, you'll remember that phenelzine, which is a MAOI, a monoamine oxidase A inhibitor. This is a monoamine oxidase B inhibitor, but the other ones, the ones in mental health, also you cannot take tyramine with them. Same thing here with the MAO-B inhibitors. I said MAO-Is for the mental health one. This is MAO-B. We're not going to distract ourselves with the mental health one, but just wanted to make that connection for you with the tyramine. The two drugs that you can't take tyramine with it are phenelzine and selegiline. Also with this medication, be careful that it interacts with a bunch of mental health medications, such as the tricyclic antidepressants. The COMT inhibitor we talked about just a few minutes ago. The drug over there is entacapone. Hopefully I'm pronouncing that correctly. We already discussed its mechanism of action. It's used for Parkinson's disease. It can be used by itself. I don't know that it's really done that way. I don't specialize in neuro, but it can be done that way. But most commonly, to my knowledge, it's added to levodopa, carbidopa as part of the Parkinson's medications. Next, we have anticholinergic, and this is going to be the last one of our Parkinson's medications, and this drug is benztropine. You may have seen benztropine in the past because we've discussed it as a drug that's used to treat EPS, extrapyramidal symptoms. How does it work? Well, it's an anticholinergic like tons of other drugs, and this one blocks cholinergic receptors. This one is specifically used for Parkinson's disease and EPS, and the primary symptom of Parkinson's disease that this would be used to treat would be the tremor. And because it is an anticholinergic, definitely for test purposes, make sure you understand to recognize any of the anticholinergic side effects. This patient may be susceptible to them, such as dry mouth, dry eyes, urinary retention, constipation, etc. Next, we have the drug, the one and only drug that we're going to talk about for multiple sclerosis, and that is interferon, or interferon beta 1A or beta 1B. The mechanism of action of this is not completely known, but it is used for multiple sclerosis plus interferons. Over there, it's interferon alpha. Over here, we're talking interferon beta. But interferon alpha is used for the treatment of viruses. However, over here, we're talking about interferon beta. This is from neurological diseases. So over here, it can cause flu-like symptoms as a side effect, as well as hepatotoxicity. Because of those flu-like side effects, and most of the textbooks I looked at said that it happens in most patients, that they will develop that. We do pretty standard pre-medicate patients with something like an NSAID to prevent them from developing those flu-like symptoms. These are parenterally only. It's a sub-Q injection taken at whatever interval. So just educate your patient about that, and also know for test purposes that it's not an oral medication. Other drugs that can be used for multiple sclerosis that we're not going to get into here include monoclonal antibodies and immunosuppressants. Next, let's talk about skeletal muscle relaxants. The drugs we're talking about over here are baclofen, Carisprotol, methylcarbamol, cyclobenzaprine. Probably some of the more common ones that you may have heard of is Robaxin or Flexeril. These are muscle relaxants. Contrary to what a lot of people think, these are not controlled substances. These are also not pain medications. These are muscle relaxants. Now, if a muscle is spasming and causing pain, it can help to treat that, and it does help to treat that, but it's actually not a pain medication. The mechanism of action, it varies throughout each of these. However, one common theme between them, and I think that's as much as you would need to know at the RN level, is that they all act as they all have their action based on their CNS depressive abilities. Now, the indications for this is muscle spasms, and the adverse effect of this is CNS depression because that's how they act. Cyclobenzaprine specifically can also have anticholinergic effects. All of these drugs, because they can't suppress your CNS, should not be taken with alcohol or any other CNS depressant. There is one other medication that is not commonly taught in nursing curriculums that I've seen, but it is in all your textbooks. So let's talk about it real quick, and that is dantrolene. Dantrolene works by suppressing the release of calcium. If you remember from A&P, calcium is one of the most important ions responsible for muscle contraction and muscle movement. And we use this medication for spasticity and also, completely unrelated, for malignant hyperthermia. That side effect of this medication is weakness, which makes sense. If I'm relaxing the muscles, it makes sense to be weak. It does have a black box warning for hepatotoxicity. Again, you should know by now, anything that says hepatotoxicity, make sure you check for history of hepatitis or alcohol use, check their AST, ALT, things like that, classic nursing pharmacology questions. Plus, this medication, you should not take it with alcohol or any other CNS depressant, same as the other muscle relaxants. Now, benzodiazepines are also used as a muscle relaxant. And we're going to talk about those in just a minute when we get to seizures, but let's take a second here and talk about Botox. Botulinum toxin, again, this medication can be used to relax certain muscles. And I am discussing it here because I didn't have another good place to put this in the entire pharmacology series. In reviewing all the different nursing pharm textbooks, I found this in a few different places. We're going to discuss it right here. The drug name is onabotulinum toxin A. The mechanism of action is that it inactivates muscles. What do we use it for? A ton of different things. Migraines, overactive bladder, cervical dystonia, that's neck muscle spasm, hyperhidrosis, sweating. I'm not going to read you this whole list, but we have a ton of different things that we use Botox for. Side effects depends on what we're using it for, what we can have. However, it's pretty common to have pain at the injection site and muscle weakness or other things like that. Again, more localized to the injection site. Please know that these drugs do take several days to several weeks to work, and generally their effects last for several months. You should warn these patients that the side effects can also occur or last hours, days, or even weeks. Also, make sure that the actual injection site is not manipulated or rubbed or excessively stimulated in any way, because we don't want that medication that was specifically injected into the target muscles or tissues to end up anywhere else. Now let's talk about seizures, but I first want to wrap up muscle relaxants. Benzodiazepines are used both as a muscle relaxant. In fact, it's commonly used as that. Plus, these are also the classic seizure medication for a patient having an acute seizure. So we're sort of going to tie those two sections together. We're going to talk about benzodiazepines, and then we'll get into the rest of the seizure medications. Benzodiazepines is a pretty big class of drugs. It includes lorazepam, diazepam, midazolam, that's Ativan, Valium, Versed, and there's a whole bunch more. How do these work? These are GABA agonists. GABA is the brakes of the brain. You press the brakes, things stop, things slow down. GABA is the brakes. If you give a GABA agonist, you are activating GABA. You are going to hit the brakes of the brain. You're going to slow things down, which if you give enough of that, you're going to get more and more CNS depression, and the patient's going to end up completely comatose if you give them enough of it. GABA is officially known as an inhibitory neurotransmitter. It's a neurotransmitter that inhibits. What do we use it for? Well, I already mentioned we use it as a muscle relaxant. I already mentioned we're about to talk about seizures. Plus, we use it because it can knock someone out. We use it for anxiety, sedation, and insomnia. The side effects are obvious. It's going to be muscle weakness because it causes that CNS depression. It can also cause hypotension, so be very careful giving it to a patient who has a lower borderline blood pressure. It can certainly cause sedation and respiratory depression. Again, just like we learned extensively with opioids, if you already watched that lecture, definitely look out for the respiratory depression. These drugs do have a black box warning. Do not take it with any other CNS depressants, plus the standard black box warning for all controlled substances that it can cause addiction and dependency. The benzodiazepines are the first line drug for an acute seizure, meaning the patient is right now seizing, but it is not meant to be a first line drug for long-term seizure management. We're about to spend the next few minutes talking about all the different drugs that patients take on a daily basis to prevent them from developing seizures. However, for a patient that has not having a seizure right now, we just want to put them on a daily medicine. This is a poor, not good option. Patient education for this, we already mentioned, don't take it with alcohol or any other CNS depressants. If a patient overdoses on this, and this is a common nursing school test, there is a reversal agent. It's called flumazenol. In real life, flumazenol is not used a whole lot because it has a rear side effect that it can cause seizures. If you give a patient flumazenol, you're blocking benzos. If now they end up seizing, you're sort of screwed because the medication for that is benzos. So that's why we don't use it a whole lot. Fortunately, we don't need to. We have supportive treatment that can facilitate the recovery of pretty much every patient who overdoses on benzodiazepines. Now let's get into the next part of seizures. So now let's talk about not about acute seizures, but someone who has epilepsy. They have long-term chronic seizure disorder. We want to put them on a medication to prevent them from ever having seizures. Let's talk about this. First of all anti-seizure medications should be tapered, never stopped suddenly. If a patient runs out of their seizure medications, they are very likely to end up right away within a matter of days or weeks or even hours developing a seizure. So we always want to make sure that seizure medications are tapered, never stopped completely. I also want to point something out to you. A lot of times a patient can tell you, I've been taking the seizure medications for the last 15 years and I've never had a seizure. Can I stop taking the medication? I mean, I haven't had one in 15 years. I don't need it. First of all, you're an RN, so don't answer that. But second of all, keep in mind this. In real life, no, they cannot stop taking it because it's very likely that the whole reason they haven't had a seizure in the last 15 years is because of this medication. So definitely, just because someone hasn't had it for 15 years, it could entirely be because of the medication. Very often, they're going to keep taking that medication for the rest of their life. If they have a reason why they want to stop it, talk to their provider, the neurologist, or possibly their primary care, but more likely the neurologist, about slowly coming off of it and trialing and see how they do without the medication. Folic acid is recommended for any patient who is pregnant who is taking anti-seizure medication. Why? Because a lot of these anti-seizure medications are not great ideas in pregnancy, but obviously having a seizure is even worse. So we generally do keep them on their seizure medicine or get them to another seizure medication that's relatively safer, but none of these are great. So we do often recommend folic acid. When a patient is pregnant and does have epilepsy and they do need to be on a medication, we may try to get them to one of the safer options. But at the end of the day, having a seizure would be way worse than pretty much any of these drugs. So we're going to keep them on some form of a medication for seizure management. Let's go through these medications. Oh, oops, almost skipped. There is a non-pharm intervention that I've seen in just a few textbooks. I just wanted to throw it in here as an extra bullet point. There's something called the ketogenic diet, which is a non-pharm intervention for the prevention of seizures. Again, I only saw that in a few textbooks, but I figured I'd throw it in. Next. The first drug class we're going to talk about for long-term prevention, I don't have this in any specific order. There is no universal first-line drug for the chronic management of seizures. One of the drugs we're going to talk about in a little bit, Keppra, is the one I see most commonly, but there's really no universally considered first-line drug. So we're just going to go through all of these and consider them equal. The first drug class is hydantoins, and that is going to be phenytoin or fosphenytoin. Fosphenytoin eventually just turns into phenytoin in the body. Both of these work by prolonging sodium channel inactivation, which is used to reduce the frequency of seizures. Obviously, these are used for seizure disorder. It does have a side effect of dysrhythmias and hypotension. It has a black box warning that when it's given IV, it has to be given very slowly. Now, this can reduce a patient's vitamin K. If you remember from the coagulation video, vitamin K is used for clotting. So the patient may need to supplement with vitamin K, which is available over the counter. It is toxic to the local tissue. So if the patient's IV infiltrates, we may have to deal with the issue of extravasation. This medication is teratogenic. You can see that a bunch over the next few drugs. So let your patient know that, and that it's not ideal for a patient who is female of childbearing age. But also, not only that, so you're going to say, well, it's teratogenic, just don't become pregnant. Here's some birth control. Well, this and a bunch of the other ones also lower the effectiveness of your birth control, which really sucks. But if a patient is female childbearing age and they have to be on these medications and they don't want to become pregnant, we may put them on birth control, but we may still advise them to use alternative methods in addition, such as condoms or something else. Next drug class we have is succinimide. The drug over here is ethosuximide. This is famously the one drug that we have for absent seizures, and it is only used for absent seizures, and that's a common test question. It works by blocking specific calcium channels, and it increases the seizure threshold, meaning it makes it harder for the patient to develop a seizure. Next, we have barbiturates. Many people have heard of this drug class. The drug over here is going to be phenobarbital, and this is another GABA agonist. You've seen that a few times already, such as with benzos and muscle relaxants. They're all GABA agonists. These drugs are used for sedation as well as seizure disorder. And because they're a GABA agonist, they can cause that respiratory depression, that CNS depression, sedation, and low blood pressure. Phenobarbital is less sedating than other barbiturates. It is still a controlled substance. It's a Schedule 4, just like the benzos. And again, just like the last one, it can reduce vitamin K, so a patient may need to supplement. And again, like the last ones, don't take it or know that it can reduce the effectiveness of your oral contraceptive. And because it's a CNS depressant, don't take it with alcohol or other CNS depressants. Next, we have valproate. Valproate, in terms of pregnancy, by the way, would be the worst drug, anti-seizure drug, to be on for a female that is of childbearing age, because this one is highly teratogenic. The drug over here is valproic acid. It's used for seizures, migraines, and bipolar disorder. It works in a few different ways. It is a GABA agonist, but it doesn't have that strong sedating effect. But it does work. I think it's even more so, primarily works by prolonging sodium channel inactivation, as we saw earlier with didantoins. The side effects over here are weight gain and thrombocytopenia. Black box warning, it has 3 of them. Hepatotoxicity, it's highly teratogenic. We talked about that, and pancreatitis. Because pancreatitis, we don't see that very often in our pharm class, but remember, because of that, make sure you're assessing a patient for any issues that can cause pancreatitis, and checking possibly the labs for it, amylase and lipase. Next drug class we have, I do not know how to pronounce it, so I'm not going to try, but the brand name is Tegretol and the generic name is carbamazepine. This one again works by prolonging sodium channel inactivation. This drug is used for both seizures and bipolar disorder. You can notice a lot of crossover. If you've already watched our mental health lecture, there is significant crossover between mental health and seizures, especially in schizophrenia and bipolar disorder. But the side effects of this medication can be neurological effects, specifically when starting treatment, not so much for long term. This has the same issue with the vitamin K and the same issue with reducing the effectiveness of birth control. This does have 3 black box warnings, different than the last one. These are Stevens-Johnson syndrome / toxic epidermal necrolysis, plus aplastic anemia, plus agranulocytosis. Those are the 3 black box warnings. Next, we have lamotrigine and levetiracetam, which is Lamictal and Keppra. I referenced both of these earlier. These are 2 of our more common, at least in what I see as the most commonly used drugs for the prevention of seizures. But again, neurologists do a lot of work with this, of making sure to find the best drug or the best combination of drugs for their patient, because we really want to get a goal of 0 seizures to our patients, period. They should never have to continue having that. Better they take their medication every day and never have that. So let's start with lamotrigine. How does this work? It prolongs sodium channel activation. We've seen that a few times already. Plus, it also blocks certain calcium channels, and it blocks glutamate. The indications over here are seizure disorder. This is also used for bipolar disorder. I already mentioned this is one of the best things for pregnancy. And this does have a black box warning, just like the last one, for SJS/10. And again, like you keep seeing over and over again, it can reduce the effectiveness of birth control. Next, we have levetiracetam, which is Keppra. We don't know exactly how this works, but this is used for seizure disorder. Again, one of the best options for pregnancy. And again, it can reduce the effectiveness of birth control. Finally, we have next we have gabapentin. Gabapentin is actually a seizure medication. However, most of the prescriptions for gabapentin are not for seizures. Most of them are for neuropathic pain, or sometimes for migraines or anxiety. So most of its use is actually off-label, which is interesting. We see that a time or two. But this medication is officially a seizure medication, so it will be covered on your nursing pharmacology section within neuro. The side effects are fatigue, dizziness, and peripheral edema. And this medication, like every single seizure medication, I don't know why I put it here and not everywhere else, but they all must be tapered. Next, we have topiramate, which is Topamax. This medication works by prolonging sodium channel activation, blocks sodium calcium channels, blocks glutamate, and is a GABA agonist. I'll tell you, in general, this is a very complicated medication. This is not something usually that a primary care even touches. This is something that neurologists deal with. This medication is used for seizure disorders. It's used for migraines. It also has some off-label uses that we're not going to get into. But this does have significant side effects. One thing that it is a little bit famous for is that it causes weight loss, which is generally considered a good thing in most patients. But there's a lot more to it than that. I'm not going to get into it. I didn't see any of the nursing RN textbooks go too deep into that. But this is officially a seizure medication. And like I said, it does have off-label uses. Patient education, again, like all the previous ones, it can decrease the effectiveness of your birth control. Next, we have pregabalin, which is Lyrica. Lyrica, I put it here because it is officially used for seizures, but again, this is also something that's used much more for fibromyalgia, to my understanding, than really for seizures. It is a neuromedication, so that CNS effect is going to be a common side effect. Plus, it can cause weight gain, visual disturbances, and peripheral edema. This drug, I skipped the MOA, but it works by inhibiting neurotransmitters such as epi, glutamate, and serotonin. That wraps up the seizures. Let's get to the very end of this lecture. We're going to end with sedation and paralytics. This will be the last few minutes. So the most commonly used sedation drug in the United States is going to be propofol, or more commonly known, or more correctly known as Diprovan. We don't know exactly how this works, but this does activate GABA, which we know is a CNS depressant. It is used as an anesthetic for both the induction of anesthesia and the maintenance of anesthesia, and it is used as a sedative. Now, this medication is a respiratory depressant and hypotension, and it's very good at both. So carefully watch your patient's respirations and their blood pressure if they're on this medication. This is IV only. There is something called propofol infusion syndrome. I see this more on the nurse practitioner level exams, but you can see it on your RN level exam because it is in your textbooks, all of them that I've looked at. And that involves acidosis, cardiac and renal failure, and rhabdomyolysis. It's definitely something that the nurse is responsible for monitoring the patient's cardiac and renal function in order to know if propofol infusion syndrome is developing. Next, we have etomidate. I didn't see this in most RN textbooks, so I'm just going to skip over it. But if you want to know, it's a general anesthetic, and it's used primarily for the induction of anesthesia. It is IV only. It doesn't really have any side effects. It doesn't last for long. It's not something that's commonly tested on at the RN level. Next, we have ketamine. This is another one. This is in most of your textbooks, but I didn't see this really come up in any nursing test banks that I reviewed. But the mechanism of action is that it's an NMDA receptor antagonist, but it's also known as a dissociative anesthetic. It's used for anesthesia, and it can cause delirium and hallucinations. This is very famously where the patient becomes separated from the rest of their being, that their mind is unable to process anything that's coming through the messages to the body, from the body to the brain. That's why it's dissociative. This is a controlled substance. It is certainly highly addictive if it was abused. Unlike other agents, this one does not lower your heart rate and blood pressure, or at least specifically your blood pressure. This one can actually, if anything, increase your blood pressure. Now, we certainly don't use it to increase blood pressure, but if someone has a low blood pressure and they need a sedative, propofol would be a terrible choice. This would be a good one. Again, assuming everything else makes sense. In low doses, this medication can be used as a pain medication. That is an off-label use. That is commonly done now, especially I know I'm a paramedic, so EMS throughout the country is getting pretty into using ketamine for pain management. It's phenomenal for musculoskeletal pain, where patients have severe broken bones and some major trauma, that it's able to really help their pain much more than a lot of the other ones, with not as much risk relating to the traditional opioids, that if I give them enough pain to take away their severe trauma pain, I might knock out their respirations. With this, I don't have that issue. So it is pretty good for that, and it is becoming more popular because of that reason. Next medication we have is Precedex. There's no way I'm going to pronounce his name correctly, so I'm not going to try. We'll call it Precedex. Mechanism of action is unknown. This one is used for agitation related to bipolar or schizophrenia, but more commonly, this is used as a sedative agent. This is used in the ICU for patients that are not on propofol. They're very often on Precedex. This is one of the most commonly used agents for sedation in U.S. ICUs. Side effects are hypertension of bradycardia. Patients may develop a tolerance or withdrawal to this, especially if they're on this for long term, which goes for a lot of different medications. This is IV only. And then just to round up our sedatives, benzodiazepines can be used in the acute setting, and they commonly are, where a patient has, let's say, a Versed drip hanging as their long-term sedative. Again, the options really would be propofol, would be Precedex, would be a benzo like Versed. It's possible to use ketamine, but that's not as common, at least not in my experience. Finally, we're going to wrap this up by talking about neuromuscular blockers. Neuromuscular blockers, also known as paralytics, are divided into two categories. There's depolarizing and non-depolarizing, meaning every single cell in our body has an action potential. So there's two ways to paralyze someone: either block that action potential from happening or discharge that action potential. So now the body has to reset, so to speak, that action potential before they can move again. The differences being as follows. If I block the body from activating any action potential, then the body cannot move as long as I'm blocking it. The patient is paralyzed. However, if I discharge every drop of action potential every single cell has, then it's just going to take them a few minutes to build it back up, and then the patient is good to move again. And that's where we have our biggest difference. A non-depolarizing drug like vecuronium or rocuronium can last 30, 60, 90 minutes, versus the depolarizing ones are going to last just a few minutes as the body resets their action potential. That's really the biggest difference between these two classes. Let's pull them both up. So one inhibits depolarization. Let's start there. So that's vecuronium and rocuronium. These inhibit depolarization. These are neuromuscular blockers. They're used for intubation. They're also used to maintain paralysis if needed. And there's a few very unique situations about where we would do this if a patient's in status epilepticus that just we cannot for the life of ours get the patient to stop seizing. We may do it. Again, that doesn't fix the problem. It just prevents other sequelae, other complications. There's a few other rare cases where we put a patient on it, maybe in the ICU when they're ventilator incompliant and it's messing with their respiratory and cellular oxygenation. Again, I'm probably going off in the weeds too much over here, but just FYI, these medications are used primarily to keep a patient paralyzed. We don't do it very often. We certainly don't do it on any sort of a routine basis. Every single patient who is paralyzed must be getting mechanical ventilation, meaning they need to be hooked up to a ventilator. Why? Because the diaphragm is paralyzed. The diaphragm is paralyzed, and you are not breathing. So you better be breathing for your patient. This medication does have a reversal agent. Also, this medication provides no analgesia or sedation whatsoever, which is one of the most important things you as the RN must understand. A paralyzed patient, even though they cannot move, and I guarantee you they can't talk and can't complain of pain, they still feel everything. Unless you have them sedated or by some other means they are unconscious, they must, no exceptions, also be getting a sedative and or an analgesia, because you will not know if they're in pain because they are paralyzed. Keep that in mind, but they will still feel every single drop of pain. Not to go off on a tangent, but there is a famous movie, Law-Abiding Citizen, where the person was paralyzed, they couldn't move, but they still felt every single drop of pain. Finally, we end off with the acetylcholine. That is the depolarizing musculoskeletal blocker. This is the one that I said it discharges every drop of action potential. So because of that, for the next few minutes, as the body sort of resets, it cannot move. This does last only a few minutes. This is much more popular for intubating patients because it only lasts a few minutes. That's a tremendous advantage. Keep in mind, and not to go off on a tangent, but if a patient is being intubated, that means we're taking over their airway. If we fail to take over their airway and we paralyze them, we're screwed, because now we fail to take it over and we paralyze them so they can't do it themselves. If I give them a short-term paralytic that just takes a few minutes, then even if I fail, in a few minutes, they're back to having control again and they can start breathing again, hopefully. Hyperkalemia and malignant hyperthermia are the two classic adverse effects. There is something to it that if a patient has hyperkalemia, they should not be given this medication, that you should check the potassium before giving it. Very often in real life, we may not know that, or we may negate the risk in some shape or form, but textbook, nursing school purposes, hyperkalemia and malignant hyperthermia are two big adverse effects, and definitely keep an eye for both of those and possibly avoid using it if a patient's at risk for either one of those. This is the only one that's a neuromuscular blocker that works by depolarizing. All the other ones, the Vecuronium, the Rocuronium, those all work by blocking. Because this one discharges every action potential, every single cell in the body may fasciculate. It may have some sort of twitching or movement because we're discharging all of its action potential. This one will wear off in just a few minutes. So within a few minutes, the patient will be breathing again unless we do something else like sedate them, which is the most common practice. Because this is a paralytic, just like I said earlier, the patient must be ventilated, no exceptions. And again, because this paralyzes the patient, even though they can't complain of pain and they can't move, they certainly, absolutely no exceptions, need some analgesia and or sedation. Here are the references from this lecture. Hopefully you enjoyed the video. Please subscribe and like it. And if you have any questions, please reach out. Have a great day.